Should save.
Yeah. Okay. Good morning, everybody. It is February 3rd, 2022 for recording purposes. Just throwing that out there. We'll go ahead and get started. If you want to swipe all of that junk away, I guess we can.
And you confirmed everyone can hear us and everything.
I haven't yet. Everybody on Zoom, can you guys hear? If you want to unmute or give me a thumbs up in the chat or something.
We're good over here.
Now that I totally took that away.
Yep, it's good.
We should be fine. I usually get text messages too if they can't hear.
Okay, sounds good.
Get that out of the way.
Okay.
Do you want to expand?
Yeah, we can
that?
expand that. We should be able to click slideshow. People should still be
You
able
can
to hear.
also get rid of that other bar if you go to more.
Oh, okay. I'm okay. It's okay.
Okay.
I don't think it should impact the slides.
Okay.
If it does, I'll move it.
Okay, cool.
All right. Hey, everybody on the Zoom. I'm Dylan, and I've met pretty much everyone here. Thanks, everyone, for your time these last couple of weeks and all your excellent care. Today's topic is just toxicology in the Pacu and perioperative setting, which kind of translates to overdose, essentially drug overdoses, medication, like prolonged medication effects, and things that we deal with both in pre-op, but really in Pacu. So we'll walk through some cases. Feel free to jump in with questions, very informal, and interrupt me at any time. I sprinkled in some photos too, some family photos to just break up the monotony here this morning. So these are just a couple of learning objectives we'll talk about. Like I mentioned, common overdoses that we see in the PACU, kind of as they relate to anesthesia care, and then talk about delayed emergence. You guys had a talk on this, I understand, a little bit ago, but we'll kind of just refresh an algorithm for thinking about delayed emergence, and then kind of refresh the steps in managing emergent situations, ABCs, reviewing patient history, talking with different team members, and then we'll go through some of these case examples here. Here's the family. My wife Lauren and Jamie, our 1-year-old now. He loves the Halloween. We did like a Western theme. He loved it. And then he loves going to breweries and restaurants. we just prop him right up on the table. He loves it. Oh yeah, no, he loves it. He loves it. He can be as tired as all get out, and he'll just sit there and be happy for now. So we'll start with a little case here. We've got 68-year-old male, past medical history of obesity, type 2 diabetes. He's on insulin. Stage 4 kidney disease, high blood pressure, COPD, OSA, a typical Michigan patient here, who underwent emergent laparotomy for a strangulated hernia. We just received handoff in the PACU. Vitals at this time are heart rate 65, respiratory rate is 8, shallow breathing. His O2 sat is 88, blood pressure 108/50, and his temperature is 35.5. So these vitals are not uncommon, as we've all seen in the PACU in the immediate handoff period. We get report that the surgery was uncomplicated. The airway was pretty easy DL with a grade 2 mass. He received 50 mics of fentanyl and 10 of morphine right at the end of the case, and was reversed with Sugamidex. He also received 2 liters during the case. There was no significant blood loss. Over the next 10 minutes, though, after handoff, you notice that his SpO2 is dropping pretty consistently. It's 85. We've repositioned the pulse ox. We have a good waveform. We've tried the other finger and ear probe, and it's really just hanging out below 90. He's not really following commands. He's pretty sleepy still, difficult to arouse. And then, as we mentioned, his respiratory rate is deep and slow now, and it's 5 per minute. So what are there any things that kind of with this case jump out to you guys? Thoughts about what could be going on, things you want to maybe know about or ask the Pacu resident or the surgery resident or the handover, just shout some things out.
Risk factors right off the bat, so.
Yeah, for sure.
Obesity, OSA.
Yep,
10 milligrams of morphine at the end of the case.
yep.
So, and a laparotomy with, meaning that he's gonna have pain in his abdomen already.
Yeah.
So,
Every time he takes a deep breath.
Yeah.
Probably not gonna take as deep. But
Try to.
Yeah, so I'm hearing maybe trouble with just taking a deep breath. That could be causing some issues with oxygenating here, hypoxia. You mentioned he got a fair bit of morphine. We'll just assume for this case, this patient's opioid naive, not on chronic opioids. So 50 mics fentanyl with like a push of 10 of morphine at the end of the case, that's a hefty dose. Exactly. What else in here? We see that he was reversed with 2 Gamedex, so that suggests that there was some type of paralysis in the case. Yeah, those are the big things. Probably received some type of anxiolysis or benzodiazepine medication for rolling back to the OR or in the initial stages of the OR. So yeah, those are all important things to think about. OSA probably has a thick, obese neck. These are all things that can impact oxygenation. So this is exactly right. These are the next steps. We just kind of talked through medications he might have taken or have been given intra-op, and then these drugs, benzos, opioids, neuromuscular blockers, reversals, things like that are important to kind of come to mind. So just a little more info. The patient's O2 values continue to drop. Now we're at 80. He's still somnolent. He's not really responding. So what do we want to do? So first thing, call for help. I think anytime we're dealing with a emergent situation that anyone that you just can't get your hand on and easily resolve with like a chin lift or a jaw thrust or the O2 cannula or non-rebreather, call for help right away. And think about some airway interventions you can perform. So that'd be something like a jaw thrust, suction the airway, put an oral airway in. You get everyone's, a nasopharyngeal air. We had a case, yesterday where someone was very, very sleepy coming out, that was kind of planned. They had some developmental delay and had received a lot of PO midazolam in addition to IV midazolam, so very sleepy. We put in an MP airway. Give as much oxygen as you can. Encourage deep breaths if they are awake. This patient is sleepy, but they're generally responding to commands. And remembering the ABCs. So you can't really have breathing and circulation without airway, and kind of thinking through those essential steps from the beginning to make sure that they're protecting their airway are important. So let's say, this patient in particular, we've identified that amount of opioid was too much, and that they're not breathing because the respiratory rate's 5 and they're not taking good breaths because they just got all that opioid, 10 minutes ago, 15 minutes ago. Now the morphine's reaching its peak effect. The fentanyl's acting. So we have Narcan, which is a reversal agent for opioids. Everyone, I'm sure, has either seen it used or used it themselves at the bedside. And it comes in a vial that's 0.4 milligrams per 1 ml. And you can usually give 0.4 milligrams every couple minutes up to 2 milligrams in the acute setting. Now, you don't often give that high of a dose if they're stable, but they're just really somnolent and sleeping. You don't want to take all their opioid off. You can give a smaller dose. You can dilute that 0.4 milligrams in 10 ml and get 0.04 and then titrate in a couple cc's at a time. But if it's like this case where it's an emergent situation, we need to get them breathing, you just do the whole 0.4 milligram dose. Also think about benzos. So if it's opioids and benzos on board, but they received more benzodiazepine medications and they're really not responsive, really not breathing well, you can use flumazenil. And this is a benzo reversal. I have not used it yet here in the Pacu in the last couple of weeks, but I'm sure it's been used. And again, it's 0.2, it's simple to remember, just 0.2 milligrams every minute, and you can use up to 1 milligram for the flumazenil. And these act quick. I think that's important to highlight. So if you are giving these medications and nothing's improving, chances are it's something else. Because like in a couple minutes, you should be seeing less, really a minute or less, you should see the Narcan waking someone up. Same thing with the flumazenil. So yeah, I think, yeah, you do.
Yeah, it's
Yeah.
not, I think we can get it just on the pharmacy like quickly, but it is done in the main one. Okay.
So again, this is kind of what we talked about, but again, just as a refresher, opioids work as agonists at mu receptors. They work on many different opioid receptors, but the receptor that we most care about in the Pacu are the receptors that cause analgesia, but also the things like respiratory depression. These are the mu opioid receptors. And you essentially block ascending pain signals to the brain. So the brain perceives less pain when opioids are on board. But as we know, many side effects, sedation, respiratory depression, nausea, itching, gastric emptying issues, delayed GI motility, pupillary constriction, constipation. So they're definitely not without side effects. And then we've kind of already talked through how overdose of opioids presents. And benzos, they, just a refresher, work on the GABA A receptor and actually cause a hyperpolarization of the neuron. So it makes it harder to generate an action potential for the nerve cell. And it presents similarly to opioids in terms of sedation, dizziness, respiratory depression, and there's the flumazenil again, is a reversal there. So let's say we do that. We gave our naloxone. I didn't put it here, but we gave some flumazenil because the naloxone didn't work right away. But we don't really see an effect. So upon review of the intra-op records and the handoff, it's noted that this patient was actually given cisatracurium. So this patient, if you recall, had CKD stage 4. So we'll assume their GFR was very low. Rocuronium and sugammadex are metabolized through the excreted through the renal system. So oftentimes with people with very bad kidney disease, we don't use those. We use cisatracurium as a paralytic because that's just degraded over time in the blood plasma. And so for this case, we see that it was cisatracurium that was actually used. Sugammadex, if you remember, does not reverse cisatracurium. It only reverses rocuronium and drugs that are chemically based on rocuronium, which are things like vecuronium and pancuronium. But this patient's still not breathing after the Narcan and flumazenil. So what do we think now? Neuromuscular, you had mentioned residual, some neuromuscular blockade. And in this case, it's very likely residual blockade because we didn't give the correct reversal. It was an error in the OR. And this does happen. So this patient comes out, you get a twitch monitor and we check their twitches, and maybe they have like 1 or 2 very weak twitches. They don't have 4 strong twitches. You can't stimulate a contraction and maintain sustained contraction. That's like a good marker of neuromuscular recovery. If you can do sustained stimulation on like the ulnar nerve and you get like sustained tetany or contraction, you can't demonstrate any of that. So next step would be to consider reversal of the cisatracurium now that we have, let's say, 2 or 3 twitches. And we can give neostigmine and glycopyrrolate for that. The way that works is just so neostigmine, if we think back through the mechanism of these drugs, neostigmine is an anticholinesterase. So you basically you stop the degradation of acetylcholine. So you get more acetylcholine building up to outcompete the cisatracurium in this case and relieve that neuromuscular block. So you give the neostigmine, and we always give glycopyrrolate, which is an anticholinergic medication, to mitigate primarily the bradycardia that comes with neostigmine. So there's some mnemonics out there, but not for remembering the effects of each of these drugs, but essentially the glyco is always paired with the neostigmine to avoid the side effects of the neostigmine that we don't want. And the ratio is you typically give 0.2 milligrams of glyco for every 1 milligram of neostigmine. So if you can generally remember that ratio, you can give a safe amount of glycopyrrolate for whatever neostigmine dose you give. And neostigmine is dosed based on their weight, and it's 30 to 60 mics per kilogram. So you can calculate out their dose. It's usually in the 2 to 3 cc range of neostigmine, and then the glycopyrrolate would just be 0.2 times however many milligrams of neostigmine. All right. And then I just mentioned on there that Sugamidex again is dosed based on twitches. So you guys often probably don't see really us giving Sugamidex because we hopefully have given it in the OR and we've seen, you know, the complete reversal. But if we have to give Sugamidex out here, it's important to check twitches and see what the residual blockade level is, and then we give our Sugamidex based on twitches. So if you have one twitch, again, remembering we want 4 twitches, that's an ideal scenario. You just have one twitch, we give a higher dose of Sugamidex, 4 milligrams per kilogram. And if you have two twitches or more, closer to 4 twitches, then you can give less, 2 milligrams per kilogram. Again, these dosages aren't so important to know, but I think it's worthwhile to just know, because sometimes, for instance, if you have to grab Sugamidex, do you have that in the Pyxis? No. So we would probably run you to the OR to grab it. But the Sugamidex is supplied in 2 cc and 5 cc vials. And sometimes if a patient only has one twitch and we have to give 4 milligrams per kilogram and they're 100 kilos, that's 400 milligrams or 4 ml. So we have to, if we grabbed the 2 cc vial, that wouldn't be enough, right? So oftentimes to reverse someone, you need more than just one vial. So that's kind of relevant for out here. Any questions with that, with the residual neuromuscular blockade or the opioid or benzo overdoses, kind of the reversals we use before we move on? Yeah.
Anesthesia is going to be administered in that.
I think so. Most likely, yeah, no, I don't think you guys have that in your Pyxis, right? No, that'd be something we would just run to the OR because it's in the cart in there and grab. Yeah. So if we decide that, hey, we've still got some neuromuscular blockade on board, or let's say they gave neostigmine and glyco in the OR, but it just wasn't enough, you know, we could run and get it. Yeah, for sure. And so this chart got cut off. Let me see if I can move this actually. Can I? Oh, is it more?
And then hide video panel or hide meeting control. All the way down. There you go. Oh,
yeah.
Nope. Go back up.
Hide floating media.
Yeah.
Okay, perfect. Okay, cool.
Yeah.
So then, you know, we just kind of talked through all of this, but essentially what we described is delayed emergence, right? Some delayed emergence, somnolence. I put down here, if it's not mentioned in the handoff, it's always important to ask about opioids, paralytics, benzos. Definitely working with you all the last couple of weeks has given me an appreciation for the importance of describing what medications we've given and in what doses and the timing of those medications. That's intimately important to your care here in the Pacu, so that you know what is on board, what maybe has worn off. So if someone is not giving you this information, I think it's important to kind of press and say, oh, hey, like, give me a time on that. When was the last dose? How much was the last dose? What was your reversal again? Sugamidex. Okay, so you paralyzed with rocuronium then, or if you hear that they use cisatracurium, you say, did you use neostigmine and glycopyrrolate for your reversal? You know, just asking as part of the handoff. And I think you all do a great job of that, but don't ever feel like there's too many questions to ask. I think though these are all important things to get answered in the handoff. And hopefully we are telling that information, but sometimes it doesn't all get relayed. But if we walk through this diagram, so let's say we have delayed emergence. Again, you kind of start with your ABCs, right? Think about ventilation, oxygenation, their temperature. Are they super cold? We always, make sure the airway's protected. Let's say that that's fine. But we're still having trouble. We're still not waking up. Consider our drug reversals, which we just talked through. Let's say problem's still not solved. You go down in the algorithm, and then you start to think about some metabolic issues, right? So has their glucose, this guy had diabetes, right? Maybe we gave him too much insulin in the OR and his glucose is really low. So think about metabolic concerns. You can send gases, ABGs. You're also so great at drawing those. And then consider neurologic causes, right? We had this exact situation yesterday. So someone was not moving their right side of their body after the OR yesterday. We had kind of worked through these things. We had sent labs, a gas, their glucose was normal. They hadn't had an excessive amount of opioids. They'd been reversed appropriately. And so we called the stroke code and we went to the CT scanner. So, there's lots of things to think about when we have this scenario. And you guys are the people who recognize it. So being the first line there, decline. I don't know who needs remote control. I'm taking too long. They're like, speed it up. Yeah. Any questions on this before we move on? No, perfect. All right. Let's see. V took control.
Go to the bottom, left corner. There.
Oh yeah, here we go. All right, more baby photos before we move on. So his favorite time of the day is bath time. The second we turn the faucet on, he runs in there, crawls in there. He's not quite walking yet. And then just watches the tub fill. I don't know, it's his favorite thing. So if we take him away while the tub is still filling, he freaks out. So we just strip him down right next to the tub and plop him in it, and he's happy as can be. So all right, so here's another case. 55-year-old female, ASA2, 60 kilograms, has a history of high blood pressure, type 2 diabetes, well controlled though, and OSA. She is now in the Pacu status post rotator cuff repair. She had a traumatic fall. She had an interscaling block and catheter placement for regional control, pain control after the surgery. She was given 15 cc's of 0.5% ropivacaine at the time of the block. Surgery proceeded uneventfully, and then she was given local at the site per surgery. They gave her 30 cc's of 0.5% ropivacaine, which is common to do. Surgeons often will inject their site with local anesthetic. Extubation was fine. She comes out to the PACU, but she starts to complain of some ringing in her ears and numbness around her mouth. She notes a metallic taste and some dizziness. She's also starting to feel pretty nauseous, and it does not improve after some IV Zofran. We get some vital signs, and we're cycling the cuff. We've done both arms. All the readings are low. We have 85 or 55. She's still responsive. She's, chatting with us. Heart rate's 55, a little bit on the low side. Respiratory rate is 20, and her temperature is normal, 36.5. What are you guys thinking about this case so far? Yeah, certainly. I think that's the biggest one that jumps out. Some other things to think about would be, again, the symptoms I put in here are pretty specific to that, local anesthetic overdose, but she's feeling very nauseous. She's, her blood pressure is low. Could there have been, this was a low blood loss case because it's, these rotator cuff repairs aren't high blood loss most of the time. But if it had been an abdominal case, I think, thinking about fluids, was this patient appropriately resuscitated? Is she hypotensive because she's very dry? Things like that. But no, you correctly identified that it's an issue with the local anesthetic. So we have some calculators. If you go on the anesthesia webpage, there's like the local anesthetic overdose calculator. It's called the LAST calculator. And you can type in how much volume of which anesthetic, local anesthetic the patient receives. And if you calculate her dose out, it's 125% of her toxic dose of ropivacaine. So, you know, that is most likely now we're thinking like, okay, we overdosed on ropivacaine. And this is something that can definitely creep up. It doesn't have to occur right when you give the local injection. So it can happen like up to 30 or more minutes after all the local's been given. And essentially you get blockade of sodium channels. That's the primary mechanism of local anesthetic. And there's sodium channels in the heart that propagate cardiac signals. There's sodium channels all along nerves that are crucial for propagating nerve impulses. So those are really the two systems, heart systems and nervous systems, that are affected by local anesthetic toxicity. So early signs are what she's experiencing: metallic taste, numbness around the mouth, auditory changes. These are all kind of neurologic changes, right? It's sensory changes, taste changes, blurry vision, some excitement or agitation right off the bat can occur. And then that can degenerate into nausea, vomiting, and then ultimately kind of the worst end of the neurologic spectrum, slurred speech, drowsiness, and then towards more toxic levels, you then start to get the cardiac involvement. So that's things like initially you'll see some high blood pressure and some fast heart rate as the conduction is kind of abnormal. But then that degenerates into slow heart rate and low blood pressure, and then ultimately PEA arrest if it's you know, a high dose and not treated. So treatment, again, you know, if you're at all suspecting this, just call for help early. As in all emergencies, get oxygen on the patient, and then the treatment is a lipid emulsification, or we call it intralipid. And we give that in a bolus dose and then an infusion over time. So I'm not sure. I think that's probably something we would grab. Or do you guys have the intralipid? Perfect. Yeah, perfect. Yeah, exactly. So it's bottom drawer. Yeah, so you can just crack it open and pull out the intralipid. Here is a little flow diagram for pretty much what we just talked through. But let's say we're suspecting local anesthetic toxicity. You're calling for help. We're getting the rescue kit or the lipid emulsification. And then we start to think about their weight. And essentially, it's just the cutoff is 70 kilograms. So you just ask their weight. If they're over 70 kilograms, you basically give a little bit more. And if they're under, you give a little bit less. But the doses are up here. And we essentially bolus 100 cc's. Let's say they're over 70 kilos. And then we start an infusion of 250 cc's over like the next half hour, 15 to 20 minutes. And then if they're still unstable, you can give repeated boluses. And then under 70 kilos, you can give just a little smaller bolus, and the infusion is more weight-based for smaller patients. Local anesthetic toxicity can cause seizures. Again, it's primarily a neurologic and cardiac problem. So really, airway protection becomes important. Benzodiazepines are the preferred treatment for seizures if it's degenerated that far. And we can give propofol too if needed. If there's an arrhythmia or hypotension, you can treat that via the ACLS protocols. Rarely, hopefully this doesn't degenerate into a arrest scenario. It can, but then you would do ACLS at that point. I think important to note is that you just want to avoid, obviously, more local anesthetics, beta blockers, calcium channel blockers, things that slow heart rate down. If they're in that hypertensive period, you might think like, oh, they need some labetalol, or we need some hydral or something. And most likely that's not the treatment if we're suspecting high doses of local anesthetic. So, but when this infusion starts, it's really just supportive care after that.
How long do the lipids take?
Yeah, to work. It can be pretty quickly. So, but I mean, if we're running, and it could be hopefully within an hour, but I think it can take longer if they've really received like a high dose local. And sometimes it's more like local shouldn't be injected intravascularly, but let's say they did in surgery, you know, they had their field was a little bloody. They didn't really aspirate before they injected, and they just injected right into a little vein or a little artery or something. That you can have quicker effects, and if that's the case, the lipid emulsification, if you get it on board quickly, it should bind up all that local anesthetic from the circulation pretty quickly.
Do you end up usually admitting the patient?
Oh yeah, they would get admitted, because you may have to rebolus or give more infusion, and even once you've treated the local anesthetic toxicity, you could still be dealing with hypotension and hypoxia and, you know, some of these other sequelae later on. So they'll have to be observed for
They go
sure.
to ICU or?
Probably they would go to an ICU. Yeah. Okay, some more pictures. Brunch, his favorite, also one of his favorite things and our favorite thing. He got this big giraffe for Christmas, and we don't know where to put the thing, but he loves it. We just put him on it, and he kicks his legs, so maybe he'll be into horseback riding or something later. Oh yeah, my wife got us matching jammies, so that was fun. It was good. Took some photos. And he loves our dog. She doesn't really love him yet, although she puts up with him fairly well. So yeah, this is our Christmas. Yeah. Her face. She's like, I'm not so sure about this. All right, another case here. 22-year-old female, ASA2. She has poorly controlled depression, anxiety. Presents to the Pacu after a lap chole. Had a straightforward GA. Case was uncomplicated. There were no intra-op surgical or anesthetic issues, no allergies. Medications, though, include Ativan, Wellbutrin, melatonin, and Zofran as needed. She was nauseous and anxious the morning of her surgery, so she took all her home medications and an extra dose of the Zofran. She was treated for PONV prophylaxis with aprepitant, dexamethasone, diphenhydramine, and Zofran in the operative setting. Immediately in the PACU, she's nauseous. She's given another dose of Zofran. You guys can kind of see where this is going. 1 hour into the PACU stay, though, she develops a fever where she had not been febrile before, a runny nose, excessive sweating, and an interesting tremor now in her head and limbs, which she's never had any neurologic issues. She's 22 and healthy otherwise. On physical exam, she's diaphoretic, hyperthermic to 39.4. We've given Tylenol. That didn't help. Heart rate now is 110. Blood pressure is still normal, 120 over 60s. Respiratory rate's 20. She's mildly agitated. Doesn't appreciate all the lines on her and people around her. You look at her eyes. She has some abnormal movements. Ocular myoclonus is the technical name for some abnormal beating movements with her eyes. What do we think might be going on? Any ideas? Definitely, yeah. You said, sorry, say it again, MH? Yeah, yep, malignant hyperthermia. Yeah, she probably received some gas anesthetic. Good, that's great. How about in relation to the serotonin, right? So Zofran has a serotonin effect, and after repeated doses or with some of her other medications like Wellbutrin, you can get some synergy there. And we know she's received probably too many doses of Zofran for her for the acute period here. What else? Neuroleptic malignant syndrome. Have you heard of that? It's a disorder that can present like this with the people who take antipsychotic medications. And that's related to dopaminergic pathways and excess in the brain. That's why they have a lot of overlap. So exactly, those are the things that to start thinking about. her case is actually, as mentioned, the case of the serotonin syndrome, which is really a clinical diagnosis, but it's a result of too much serotonin in the brain and the nervous system. And you see this often with patients who are taking like high doses of SSRIs or MAOIs for depression, and who come in and get Zofran repeated doses, or repeated doses of other psychiatric medicines that cause these neurotransmitter surges in the brain. So you'll ultimately get this triad of neuromuscular excitability, autonomic disturbance, and mental status change. So as we mentioned, they'll present with maybe some tremor, stiffness, myoclonus, hyperreflexia. You'll see issues with tachycardia and hypertension from an autonomic disturbance standpoint. Hyperthermia is pretty common when you have serotonin syndrome. And then there's agitation, confusion, and really when it's at its worst, coma for patients with serotonin syndrome. So what do we do to diagnose it? It's, as I mentioned, clinical diagnosis. You just got to stop the serotonergic medications. So try to really think about making sure we're not going to give any more Zofran or anything like that. We're not going to give them, let's say they are due for they're an inpatient and they're due for a dose of their SSRI or something. And that's probably not something we'd be giving in the Pacu, but important to relay that, hey, you know, this patient should not get their SSRI today, and think while we kind of sort through this treatment and management. And then this is where meperidine comes in. So meperidine has an effect with the serotonergic system in the brain. It doesn't work on the mu opioid receptor, it works on the kappa opioid receptor, but nevertheless, it causes increases in serotonergic levels. And so if someone's on an classically, if someone's on an MAOI, which is an older anti-anxiolysis drug and an older antidepressant, we don't see them as often. But if someone's taking that, we should really try and avoid meperidine. And I think this is a good plug that, you know, if someone's really shivering and shaking, that's what we jump to the meperidine for. But if they have any psychiatric diagnoses and are taking these medications, we should think twice about meperidine, because it can lead to this. There's a famous case that actually led to, I forget the name, but it led to duty hour restrictions for residents, because and was the reason why nationally we have like the standard, you know, 80-hour work week, and they try to limit it to that, because a patient came into the emergency department, was on an MAOI at home, and was just in pain and had some nausea and was shivering a lot, I think. And so they gave meperidine, and then she went to the floor. She got another dose of meperidine. It wasn't working on the floor, so they like gave a third dose of meperidine. And this is across multiple providers. So, you know, it probably just wasn't looked into her chart, and she ended up dying because she had just severe serotonin syndrome that wasn't recognized early enough. So she's had this agitation, this raising heart rate. So, oh, let's give her some benzos, you know, calm her down, and which just kind of made things worse with time. So that's why here sometimes we're a little hesitant to just give everyone meperidine, though it used to be much more common practice to just give everyone meperidine if they're cold or shivering. Other than that, otherwise, if you have stopped the serotonergic medications, you can use benzos to eliminate some of the agitation. But that's once you recognize that, hey, serotonin syndrome is what we're dealing with. Otherwise, it can mask some of the symptoms. So just like with everything, think about the ABCs, call for help, really oxygenate the patient well, and then it's really just supportive care after that. And then very rarely will you have to intubate and sedate the patient if they're like very hyperthermic, having seizures, things like that. Some more pictures. He takes selfies now. He loves his teddy bears. Yeah. All right, so another case here. I think this is the last one. We'll go pretty quick. 37-year-old, ASA3, history of hypertension, SVT, IV drug use, obesity, He presents to the PACU 15 minutes after emergence with agitation, tachycardia, chest pain, not responsive to redirection. We give some fentanyl, IV morphine does not help. Blood pressure is notable for hypertension. He's tachycardic to 125, statting well, and his temperature is 38.5. Very active, agitated gentleman. What do we think could be going on? A lot of things we kind of just touched on, right? This, I'll give you a hint. This is not a medication we gave intra-op. If we think about maybe some street medications or street drugs patients take, what could be contributing here? Maybe something that's like an excitatory street drug. Cocaine, exactly. Cocaine or ecstasy, some type of stimulating medication or drug, exactly. So for this we'll just talk about cocaine overdose. So cocaine is predominantly a sympathetic overdose. You'll see tachycardia, tachypnea, hypertension, chest pain. If it's a severe cocaine overdose, you can see myocardial ischemia as the coronary arteries constrict down. You can have abnormal heart rhythms. This will often present as agitation on emergence. So as anesthesia is wearing off, the patient's disinhibited. So maybe symptoms that were masked in the preoperative setting are kind of unmasked in the acute PACU setting. And so they don't really have the cortex control yet to kind of calm their excited symptoms down. So they're really paranoid, they're really anxious, they're sweating, they've got a headache. This can degenerate into subarachnoid hemorrhages, strokes, seizures, if it's really not treated appropriately. So again, it's just supportive care. You have to really think about the ABCs, make sure they're protecting their airway. And benzos is the treatment for severe cocaine overdose. Cocaine overdose is kind of like alcohol withdrawal. It can lead to severe complications, and you can die from these complications. So we can give benzodiazepines after we really ensure their airway and breathing and circulation is protected. Try to avoid beta blockers for these patients, because again, if you take away all their beta stimulation and they have all this alpha stimulation from the cocaine, that can worsen the vasoconstriction and worsen some of the myocardial issues as well as cerebral issues. So whereas, think it's just another plug to think about what's going on, and is labetalol or metoprolol appropriate in the setting. So that's really the last case. Pretty much, I hope we just kind of covered that. Some agitation, delirium, desaturation, remembering the ABCs. We reviewed kind of some common intra-op medications, opioids, benzos, and their reversals, Narcan and flumazenil. And then also we talked about residual neuromuscular blockade, thinking through what neuromuscular blocker was given for the procedure and were they reversed appropriately. Everyone makes mistakes. Everyone's busy at times. And sometimes, I would say most commonly, we were giving rocuronium. So sugammadex is the reversal. But in nuanced cases, we're not giving rocuronium, and that's the wrong medication for something like cisatracurium. Other than that, thinking about home medications. So, the patient who had taken a bunch of Zofran and they were on an antidepressant who then gets more Zofran and can present with serotonin syndrome. And then just a plug for really pressing us during the handoffs for all that info. Don't be satisfied by the provider who kind of pushes the handoff off and just kind of says, oh, you can look in the chart, or, that oh, I gave that a long time ago, don't worry about it. Just say like, no, please tell me the dose and when it was given, I need to know. So you guys are the crucial force out here in the PACU. So thanks for all you do. And I appreciate all the learning these couple of weeks. So look forward to working with you. Here's some more reading if people are more curious. We will send this out. But that's pretty much it. I hope I didn't cause this picture on the right here, but it's not always fun and games. But anyway, Questions? Yeah, anything we can hash out?
For like the SSRIs or
Yeah.
SLIs, I know some of our patients are older, but I didn't know.
Yeah,
And I don't know if we have anyone here to answer it, but I'm just wondering if preoperatively, if that's something that they stop ahead of time, like,
typically, no. We let patients take their SSRIs
Right up
and
to the-
right up, yeah. And to be honest, like taking their regular SSRI or MAOI dose and then receiving a dose of Zofran is probably fine for 90% of patients. But if those patients who maybe are on the higher dose schemes for their med and are taking multiple doses of meds in the setting, pre-op setting here. Yeah.
Are they with you?
So-
And-
All right, thanks, everyone.
Oh, thank you. Perfect.
appreciate it.
Yeah,
Can we just stop the recording and then that's it?
stop share.
Yeah. And then